All right, folks, buckle up. I never know where he's going to take us, but thank you for being here, Dr. Hollander. We really appreciate it. And you've returned, and last year, you also had some talk around transformation. So I want to dig into that a little bit. You're leading a lot of innovation at Jefferson, and your organization is really at the forefront of a lot of these innovations. So maybe to start off, I'll kick us off and just say you and your team are reimagining a lot of workflows. Maybe you can give us a couple of examples of that.
So I'll start with the one that's a mistake. And it's really interesting. I mean, I think some of the ways we think about it is we should solve problems that people have rather than find things that people don't perceive as a problem. So one of our biggest advances this year is something called virtual checkout. We built this new building for literally $780 million. That cost almost as much as the Cowboys Stadium, but we in Philadelphia have winners come through the building, okay? So, okay, sorry, I couldn't resist. But
What'd I say?
But when they designed the building, we wanted to maximize space for patients. We talk about access, engagement, and transformation as three of the pivots for our health system that we have to have as true north. And to get more access, you need more rooms and more clinicians. So if you have a new building, it's a great chance to build more rooms. But when the typical architect designs a building, they have rooms and they have areas for checkout and check-in and things like that. And so we gave up the checkout space. And we said, let's convert them to rooms. And our team and our IT team were asked, can you guys make this work? And we partnered with our friends and colleagues at Teladoc, and we created something called virtual checkout. It is so cool, it's unbelievable. Literally $1 billion building, and the news stories were about virtual checkout, and the health system president talked about virtual checkout. So a patient goes into the room to be seen, and there's all kinds of fancy electronics, and there's a big whiteboard, think 45, 50-inch TV. And while patients are waiting, they can learn about their doctors, their nurses, they could look at the kind of art they want to look at or listen to the kind of music they want. And when the visit's over, they hit a button, and a checkout agent pops on that screen, and we've now done about 150,000 of these. We do 600 to 1,000 a day. Checkout agent pops on the screen, it takes them 18 seconds to get on. We can sometimes, if we have the right checkout agents, match them for language. So we don't need a translator if we have bilingual checkout agents, and we can identify the language of the patient, and they schedule their follow-up appointments. So if you know anything about healthcare, the sooner the appointment is in relation to the time you schedule it, the higher likelihood it is for patients to show up for it. The better the linkages are, the better their test coordination is. So that's one of our big things. On the other side of the coin, we've looked at inpatient connected care, and here's like a great piece of math to remember. If you do telesitting and you take just 4 one-on-one sitters out of the equation and replace them with one virtual sitter, you save $1 million a year. Big, big savings. So telesitting is the return on investment that drives what we call comprehensive inpatient care. And in that setting, we have virtual nursing, we have telesitting, we have provider consultations into the room, and we're hopeful to grow it out. So on the weekends, we can have case managers or pharmacists or other people get into the rooms. We're 32 hospitals, but we're never going to get 32 case managers working Saturday morning. But could we get 2 of them that could go into the handful of people who could be discharged Saturday with a little intervention? Hopefully we can.
Well, we've talked a lot about the grit, about innovation and getting through new challenges, new problems. Can't help you with the architecture thing, but I'm glad that
worked out well.
It worked out well, that's right. You've been an advocate for hybrid care for a long time, and last year on this stage, you talked about virtual care as just another way to deliver care. Maybe you can speak a little bit about how virtual care is just part of the family, and it's how you deliver care, just another way to deliver care.
Right, so you're going to mention family, so I'm going to ask everybody to do something. I want you to stand up if you either have had or have a child, or have had or had a parent. Please stand up. Okay, you don't really have to do that, okay? But the point is, as we think through this, Oftentimes, I'm asked, what's the true north and how should we treat patients? And we should really treat patients like we would want our family member treated. And if we do that, it's a really easy thing to remember. And sometimes your family member will want to come for in-person care, and sometimes your family member won't. And I've been, I guess, unfortunate enough. Both my parents have passed on at a ripe old age and had a good life. But I went through the end of life stuff with them. And so my father, he died in his 90s, people would say, well, he can't do virtual care. Well, of course he could, because my sister, who lived a couple minutes away from him, would much rather drive to his assisted living facility and do virtual care than load him in the car, coordinate transport, and get him to a hospital. And so it really is about how do we engage. And on the other side of the coin, I'm fortunate enough to have grandchildren who, just yesterday, I get texted, look at this rash. So that's asynchronous care when I'm not home with an appointment, the way they care to get it. And I can tell you I got it right on the text message because I saw them in person later in the day. But it really is. There's not one right and one wrong. And too often people talk about in-person care versus virtual care. I'm an ER doc when I was practicing medicine. And family medicine would send someone to the ER because they couldn't handle it. That's not a failure of family medicine. That's identifying an illness. Same way that needs higher level of care. Same is true for virtual care. If you see someone on virtual care and you can't do anything, it's totally kosher to send them someplace for in-person care. In fact, it's probably malpractice if you don't. So we have to think about hybrid care and how do we tie it all together for everybody who wants care.
Well, you have been a leader in recreating workflows. This is one of those questions that I know is quite challenging, but when you disrupt the status quo, when you're making changes, you are trying to figure out how to land your change management, and I'm just curious if you have any thoughts on how to lead change management in a sustainable way.
Oh, so I have 3 thoughts that I'll share with you. One is when people call, don't answer your phone. The second is 2 people in the audience, Frank Seitz and Laura Gardner, who work with me, who actually do a lot of the change management. Change management is really, really, really hard, and it's what 95% of our life is really about. But it gets much, much easier if you do 2 things. You make sure the people you're leading down that pathway are passionate about where they're going, which means don't find a problem and solve it that they didn't know exist because they're not going to want to change. That's not human nature. So find out what is a problem and how can you solve it. So that's really important. And then, so it's passion and solving a problem that people think they have to make that work.
Yeah, and I think it's great to mention Frank and Laura because that's where the friction happens, but that's where the solutions happen. So thank you for having such a great team. It takes people, like people in this room, to get through change. Anything else you'd like to add for just how virtual care is evolving in your organization?
I think that it's good to have a big picture in where you want to go. I think it is, evolving is the right word, it's an evolution. And when we started rolling out, everybody would have said do primary care first. They were the last people that used it. I haven't told this story in a long time, but I swear to God, one of our first 3 biggest use cases in virtual care was in urology for post-vasectomy care. Now, if you have strategy people that would have come up with that as the first place to roll out, bless you. But we just let people use it where they saw it to be useful and then went with it. And so it's change if people see it having some utility, and it's not helpful if they don't.
Well, Dr. Hollander, I want to thank you for taking time to be here. I want to compliment you on your boots in Nashville. Well played.
Yeah.
I did this, I'm getting some flack, but I did this out of reverence for you. So I will shed the tie and I'll get the boots on.
Okay, all right, good. I appreciate it.
Thank you so much.
All right, pleasure.